We have just started a large national, within the UK, multi-centre randomised controlled trial called Access, Anaesthesia Choice for Creation of Arteriovenous Fistula. And it aims to randomise 566 patients across 20 centres in the UK over the next 2 years to local or regional anaesthesia for creation of their primary radial or brachiocephalic fistula. This work has been funded by the NIHR and was born out of a smaller trial that we performed about 5 or 6 years ago that was published in The Lancet, which suggested there may be improved early patency rates with regional compared to local anaesthesia. Regional anaesthesia naturally causes a sympathetic blockade, vasodilatation, improved blood flow, and it therefore follows and would make sense that that could translate into improved vascular access outcomes. So that's what the trial is aiming to address. There's two different types of blocks, two different types of upper limb blocks that can be used. A supraclavicular block or an axillary block, which are just marginal modifications on each other. Each has relative merits, risks, benefits that will vary between patients and will vary between anaesthetist preference, and the protocol has deliberately been left such that that approach can be individualised. At the Access study, the primary endpoint is 12-month unassisted functional patency. We've incorporated some cost-effectiveness analysis. It's obviously much larger and across many centres, so that there will be a natural variation between surgeons, anaesthetists, etc. involved. We've incorporated patient-related outcome measures, and also there's a embedded qualitative study as well, looking at renal patients' experience of participating in trials and the burden that that might pose on patients who are already suffering the burden of having to come to dialysis 3 times a week. One of the things that has come out of the development of this protocol more than anything else is the importance of multidisciplinary and collaborative working, because this very much is a study of a multidisciplinary approach involving surgeons, anaesthetists, nephrologists, vascular access nurses, radiologists, etc. And I think that reflects the multidisciplinary nature of vascular access. There are several aspects that relate to patient-related outcome. Obviously, this has been a big topic within vascular access with the publication of the SONG consortium outcomes, and we have taken a huge amount of effort to involve patients in the development of this protocol. So even the primary endpoint has been hugely affected by patient viewpoint, and we've specifically chosen unassisted functional patency at 12 months to reflect the importance of function and the importance of lack of intervention and the significant burden that patients feel by intervening on their access to be an important outcome measure for patients. We're also including other patient-reported outcome measures. We're looking at EQ5D, primarily for cost effectiveness. We're looking at kidney disease quality of life, looking at dialysis symptoms, both long-standing, well-recognised patient-related outcomes. But the aspect that I'm actually most interested in is we're also utilising a new vascular access specific quality of life tool that some of my colleagues, Karen Stevenson and David Kingsmore, have developed in Glasgow over the last 4 or 5 years through something called a capabilities approach. And essentially they've devised an 11 question scale which can be used to compare all different forms of access, fistulas, grafts, lines, and can be used to look at access which is utilised and access which is redundant at that point in time. So I think that this will be the first time it's been used in a randomised trial, and I think that aspect of things will be very interesting as well. As a surgeon, I'm very keen to take on any new technical procedure, but I think we also need to recognise the significant intricacies and detail and precision that is required to perform good regional anaesthesia. Anaesthetists are doing this all the time. And like most things, there is a volume related outcome, a huge amount of transferable skills between the different types of anaesthetic blocks, and therefore if you're performing multiple different blocks in multiple different areas, actually you could argue that your skill set therefore would be much better. I guess to some extent, were the trial to demonstrate the benefit of blocks, individual centres would then need to look at what their resource challenges were. And certainly for us in Glasgow, actually, it's probably more efficient now to have anaesthetists performing the blocks, because we could run a block room where the anaesthetic block is actually being put in parallel to the previous patients having their surgery. So therefore, having an anaesthetist and a surgeon is hugely beneficial and hugely efficient. Whereas in other centres, it might not be that there are a large volume of suitably trained anaesthetists, in which case there may be a rationale and a value in surgeons becoming trained in some of these skill sets as well. All of us want to practice evidence-based medicine. We want to get what's best for our patient, but we also recognise that healthcare is expensive, and therefore if we are going to change practice, if we're going to influence guidelines, if we're going to influence policy, we really do need high quality evidence to allow that to happen. Please join us, particularly at the moment when the perioperative environment's been decimated by COVID. Having something to focus on and something positive to take away is actually quite nice. So yes, if anybody's interested, please get in touch. The aim is to try and recruit 20 sites from across the UK. So if anybody's interested, please don't hesitate to get in touch.